In the same way that the tempo of combating COVID-19 is being sustained, the Nigerian government has been working tirelessly in coming up with strategies to halt the spread of HIV on a sustainable level. To this end, the mode of transmission study, which focuses on identifying the sources of new HIV infections in the country, first conducted in 2009, was recently repeated using an updated model known as the incidence pattern model. This was done to support efforts geared towards preventing new HIV infections using information that is accurate and clearly shows where new infections are occurring and among which population group. This development and the policy implications of the new findings is our focus on this episode of Health Options. Thanks for joining us on the program. I am Rabi Abdullah. If you are just joining us, this is Health Options, and our focus is on the new mode of HIV transmission pattern in the country and policy implications. My guest is the Director General, National Agency for the Control of AIDS, Dr. Gambo Aliyu. Thanks for joining us once again on Health Options, Dr. Aliyu.
My pleasure to be here.
Okay.
Thank you.
Yeah. Even in the pandemic of our time, I could see that Nigeria is, not resting on its hours to, towards ensuring that if the fight against HIV and AIDS, it's not, lowered in any way. Yeah. So on this program, we're taking a look at, a study. I don't know what it's a review. Having conducted an earlier study in 2009. You undertook another one this year that has to do with the pattern of mode of transmission of HIV in the country. So let us into that. What's that all about?
Thank you. For the last, let me say, 3 to 4 years now, HIV program in Nigeria has been largely data-driven. We look at the evidence on ground and we go after the information that is available. Because globally that is the trend. You cannot end HIV without finding out where transmission is taking place the most. And if you find out where transmission is taking place the most, you make an effort to stop the taps from running. And once that is done, the next one thing you do is to make sure that HIV is kept within individuals that have it. So no more transmission. If no more transmission takes place, then there will be no more new HIV infection and no additional people having HIV infection. The implication is that you got a mass number of people with the disease that you'll continue to use the medication we have now available to just make the virus disappear in them. We don't see it. If we don't see it, it doesn't get transmitted. And if we keep that pattern, then it will come to a time when virtually no one has HIV or very few people have HIV in them. And hopefully by that time, the scientific community may probably have the breakthrough of having a cure for HIV.
Which group is transmitting the most? Before now, if you had asked me, what I knew had to do with the mode of transmission through that's known as that's prevention of mother-to-child. The mother-to-child transmission is one we knew had remained a huge challenge for the country. Has the scenario changed? Because you have a new study now. Has it changed?
With the mother-to-child transmission, the scenario hasn't changed, and this is one of the area we're focusing. Over the last couple of months, all our program and our discussion has changed now to pay more attention to mother-to-child transmission. We cannot dream of ending AIDS or having AIDS-free generation without continuing to produce kids that are HIV positive. That tab has to stop running. We have to figure out ways to reach out to pregnant women wherever they are, get them tested at their convenience, and those of them that we found to have HIV, put them on treatment, make sure we keep them on treatment so that their baby does not get it. And if their babies don't get it, we're hoping that we can keep that HIV within the mother, and just as we keep HIV within any other person that has it. That has been difficult simply because we don't get access to the pregnant women.
Wow. From the outcome of this review of the 2009, pattern of mode of transmission of HIV in the country, I want you to give us the breakdown of your findings, because from my perusal of the study, I noticed something about unmarried men and unmarried women accounting for the highest prevalence rate. What does that, imply?
Okay, so if we look at the previous mode of transmission study we did and the recent one, I agree with you, this is the difference. Virtually most of the population groups we have in the past we've identified, they still show up as the group that are transmitting the most. These are the key affected population, men that have sex with men, the injection drug users, the transgenders, and the sex workers. As well as the mother-to-child transmission we're having simply because access to pregnant women has been inadequate. In
terms of percentage now, can you, say this, with the percentages?
Now, if we are looking at the transmission, yes, the higher transmitters are the key affected population. But if you look in general, mother-to-child transmission also contributes significantly because of the share number. Key affected population, if you look at the group, is small, is probably 2 to 3% of the general population, but the transmission that takes place within it is in quadruple multiple of what happens in the general population.
Was quite high.
Was quite high.
Okay.
And if you look at the mother-to-child transmission, you will see that the transmission is taking place especially among pregnant women that don't test for HIV. They don't know their HIV status. They don't often come for antenatal visit, and we couldn't figure out ways to reach them, maybe probably halfway. So this is where the program changes now. We're looking at ways, to reach out to pregnant women, maybe in the comfort of their residence, to let them know that the unborn baby has the right to be protected from HIV. This is something that every expecting couple should know, that the responsibility of knowing their HIV status goes beyond them. It also has to do with this pregnancy that they have. It is in the interest of the pregnancy that they know their HIV status. If any of them is HIV positive, our responsibility now is to keep the HIV within them, making sure that it doesn't leave either of them to affect this newborn baby.
Okay. I know the attendance of antenatal clinics is quite important here, and I'm sure it's part of your consideration.
Right.
I don't know. I remember what happened in the during the polio era. Some strategies then had to do with involving community leaders and I remember, some groups within the community were chosen then to monitor and track. So I don't know, do you have, plans for soil, or you already have that in place?
We have that in place. The only one thing that we get to understand now is that the communities are different in terms of the response to our call for antenatal visit. Some communities, you may find 95% of pregnant women do go for antenatal care. For these communities, our health sector, health facility response program we have for antenatal is working and should continue to work. Community intervention may not be necessary. But in places where the antenatal visit is way low, probably less than 50%, then we now know that we need to have a very strong community program that reaches out to expecting mothers at their places of comfort. Maybe it may be religious places of worship. It could be somewhere in the marketplace. It could be somewhere in their house. It could be somewhere where they have community gatherings. We've given this assignment to our program implementers at the various states to figure out how best we can reach them. Could we reach them through traditional birth attendants? Could we reach them sufficiently through the trained midwives that take delivery at their homes in the neighborhood, because we know all this take place? Or could we reach them through religious places of worship, where some of them go for services because they have doctors or health workers that provide services to their members? Or we can do a combination of virtually most of these things that I have mentioned, depending on the states and depending on what works for the various communities that are lagging behind. This is what we are adopting. So it's not one size fit all, but certainly is specific for the various communities. We are studying those communities now. We're looking at the various states and we're looking at the gaps, and we are giving the program implementers the opportunity to come up with whatever they think will best work. Let us implement it in the next 1 year. If we're able to faithfully implement that within the next 1 year, we're very hopeful that now we are talking October 2021, October 2022, we should be hitting the roof in terms of key performance indicators for achieving epidemic control, which means we have succeeded in closing most of the taps that have been running and that we have been struggling with over the years. And once that happens, the global community can effectively recognize Nigeria as one of the countries that has effectively controlled HIV.
As the DG NACA, if I just take you up and say, what we had in 2009, if we were to make a comparative analysis of both now,
what has changed?
Yes, what has changed?
Things that have changed, the way we access these population groups. There has been tremendous shift in the way the communities now respond to our service. Globally, people are getting to understand that HIV is no longer the killer disease they fear in the past. That HIV can now be effectively checked with an individual, and people now feel confident to come forward to accept HIV services, especially knowing their HIV status. Let me give you an example. When I came on board, one thing I asked is that how many people do we have on treatment, and I was told we have about 1.2 million on treatment. I said, okay, one thing I want is to see this 1.2 million. I want to see them, show me the data. And we started working then. We asked our development partners to ask all the implementing partners they support nationwide to upload data on the National Data Repository. They upload treatment data, and we get to conclude that by the end of 2019. At the conclusion of that exercise, we realized we had about barely over 800,000 people on treatment. That, okay, it's not a bad idea. But what we want now is go out in the community. We are already in the community then, but go out in the community, get these numbers wherever they are. Now, as I'm talking with you, we have 1.6 million on treatment on our database, and we can see them, and we're still counting. So with this phenomenal change and phenomenal achievement, we're looking at reaching the ceiling in terms of 95, 95, 95, which means identifying a minimum of 95% of people that have HIV in the country to know they have HIV. And among those 95% that know they have HIV, another 95% should have access to life-saving medication to keep this virus within them. And among those that have this life-saving treatment to keep the virus within them, 95% also should be doing well on the medication, which means we should see the virus disappearing in them. If you add 95, 95, 95, you're talking of about 80-something% will come down with viral load suppressed, which means when we look at the virus, we don't see it.
Okay.
So if we reach that stage, it means we have succeeded, or we are on the verge of succeeding in effectively checking transmission.
Let's look at the issue of global efforts now, because I don't know if you can enlighten us more on what I've heard about the global success on vaccine. I learned there's been something that's like 40 years work in progress that seems to have seen the light of day now. What can you tell us about that?
For HIV, the success has been minimal in terms of any breakthrough for vaccine. But for the treatment we give, especially for prevention, I think the success has been tremendous now. We have drugs now that can be injected in individual, not taking pills. For those people that find it inconvenient to take pills every day, there is an option now, and very soon we will look into getting this out in the country. There is an option. Somebody can come into the clinic and have an injection and may not bother taking medication until another 2 months in a year.
So it's actually treatment, not prophylaxis. It's not for
treatment,
prevention.
not prevention.
Oh, okay.
It's treatment, not prevention, which means these people that have the HIV now may not need to take the medication if they so wish on daily basis. They can come every 2 months to have an injection, and they can have this injection 6 times in a year. And that can effectively keep the HIV virus within them. And those ones that are also at high risk of acquiring HIV, like discordant couple, one partner is HIV positive, the other is HIV negative.
Yeah.
How do we prevent the HIV negative from having HIV and making sure that that individual does not get the virus? So the same way. There is a trial that has been on for some time and has been recently stopped because of tremendous success that they got from the trial. This drug is now at FDA in the United States, looking for license to be used in the United States, and by extension to be used in other places that may have interest in having them. So this has been a significant shift. Which
Would
means
there be a country that will not be interested in having them, or are we going to experience the wrong nationalism like we experienced with the COVID-19 vaccine?
So you can never tell. There may be countries now that are probably working towards an alternative, and if they have an alternative and that alternative is working, they may not necessarily use one that is been licensed by FDA, just the way we see with COVID. But we are hoping that...
But is Nigeria looking that direction?
No, Nigeria is looking at whoever succeed in getting something that proved to be efficacious, Nigeria is willing to use it. We don't have anything in the pipeline now at the moment that we can say is comparable to what these people have achieved at the moment. We just waiting to see data on this success, to read more about it, and to see how we can take advantage and use it on our people, so that HIV is effectively put in check.
Okay, I'm sure with the advent of the injection, a lot of more people will be more cooperative because not really many, are keen on taking drugs and all of that. But
Yeah, and it will reduce the stigma, because some people, it's not that they don't know they have HIV. They know they have HIV, but they are finding it extremely difficult to come to our facility to take these drugs, maybe on monthly basis or 2 monthly basis or even 3 monthly basis. They just don't want to come. So if they don't want to come, we can find means to take this medication close to their communities, community pharmacies, locations, clinic near their places. This is what we call community ART, which is on actually. We have a pilot project that is on and has been successful. So there are various options to which we can have this medication delivered without person coming to facility actually to take them. If the facility kind of expose somebody to stigmatization and discrimination. And on that issue also we're working to make sure that health workers nationwide that provide services on HIV are significantly or sufficiently enlightened on the dangers of stigma and discrimination and disclosure, unapproved or disclosure that has not been consented. Some of them can actually take somebody to jail or can have a combination of fine and jail. So we want to make sure that our health workers are fully aware and they are fully cooperative. Okay.
On a final note, Dr. Gambo, there used to be so much emphasis on, adolescent education, where HIV and AIDS concerned then, back in those days. And it's gets me worried when, even at this moment, I've had stories of, secondary school students who indulge in sex and at the end someone is coming out with unwanted pregnancy and all of that. What are we amplifying that, or how are we doing it this time around?
So we're looking at, because these people you're talking about, especially those ones we see in our mode of transmission, those below the age of 25, usually 20 years to 22 years, that are having the virus transmission now, part of the group that where the TAP is running, are people that usually they don't connect to our conventional programs. They hardly watch this kind of program we do.
Yeah.
They are social media.
Exactly.
So we're coming up with program that will address that, to see how we reach out to them and how we get some of their groups or associations to work with us and to find them where we can best get them and to get them to listen to us and, buy this idea of, one, knowing their HIV status, and two, whatever the status turn out to be, whether it is positive or negative, they have a duty or responsibility. If it is negative, we now teach them how to remain negative for the rest of their lives.
They should be part of the conversation because you have a bigger challenge in your hands now with social media.
Right.
Young people are visiting sites they shouldn't visit.
Yes.
And, that had come with so many, there are consequences for some families.
Yes. Yes. And you see a lot of things is taking place at the same time. Sometimes the way these things are happening is so fast that it goes beyond, or at the rate higher than whatever program you have in place or intervention. Is something that program alone cannot do. We need the community to help. We need parents to help. Don't just leave your kids like that. Talk to them. Engage them. If you don't talk to them, you don't engage them, someone else will do. And someone else will talk to them and engage them in a ways and manners that you don't like. So we should start doing that if we're not doing. But if we're doing, we should do more.
So it's the responsibility of all.
Yes.
Thank you so much, Dr. Gambo, for joining us on Health Options. We appreciate your time.
My pleasure. Thank you.
That's where we end this week's episode of Health Options. A quick reminder that you can go to our YouTube channel to watch the upload of these and other episodes of the program. Email us for your comments and contributions at healthoptions@nta.gov.ng. I remain yours, Rabi Abdullah. Thanks for watching. Hope to see you again.